delirium and circadian integrity. Really no disclosures that impact me here. I'm just a member of the ABIM Critical Care Board, the Society for Critical Care Medicine Pain Agitation Delirium Guidelines. This rhythm to external cues, and those are what become important when we're talking about ICU and the ICU environment. The one German word I have in here, which I practiced before, which I probably will get wrong, Zeitgeber or light giver, is an external or environmental cue that acts on the circadian rhythm to synchronize the Earth's 24-hour light and dark cycle. And then phase shift, which is what we often see in critically ill patients, is displacement of oscillation along the time axis. So your rhythm is shifted, either advanced or delayed. All right, oh, there we go. So just to remind people, this is the human circadian clock that functions on a 24-hour period. And what you'll see is there's lots of things that happen along this clock, but what I want to point out is these are some of the things that people measure in studies of circadian rhythm. You can see highest body temperature, lowest body temperature occur at different points on this 24-hour clock. The other thing which becomes important, or which we measure when we try to study circadian rhythm, is melatonin. And so you can see melatonin secretion typically starts around 2100 hours and stops early in the morning at about 7:30. And then the other thing to notice when you're thinking about the intensive care unit and patient care, patient flow, is deepest sleep typically occurs around 2 in the morning. And I was saying today, I was thinking this at 3 in the morning when I totally woke up the last 2 days with my circadian disruption and jet lag. So when we think about circadian rhythm and signaling, light really is our major Zeitgeber, and it works, you saw in the previous talk, light through the eyes to the suprachiasmatic nucleus, and this works to synchronize the peripheral clock. So there's the master clock in the suprachiasmatic nucleus, but there's also peripheral clocks in the heart, in the liver, in the GI tract, and there's also cellular oscillators, and there's other Zeitgebers for those. So there's the sleep-wake cycle, but there's also things like physical activity, social interactions, and meals, and we need to think about all of those when we're thinking about the impact of the intensive care unit on circadian rhythm. I guess my shaking does not necessarily work. There we go. When we're thinking about how to measure circadian rhythm, the things we can think about for studies are physiologic. So as I mentioned, you saw there's differences in core body temperature. There's also differences in heart rate variability that go along with normal circadian rhythm. Blood pressure changes. So typically highest blood pressure very early in the morning. That's been associated with onset oftentimes of myocardial infarction that occurs typically early in the day. And then actigraphy, or patient activity. And then there's biomarkers that have been looked at. The most common biomarkers are melatonin and cortisol, which have circadian fluctuations, but there are others that have been examined as well, and now people are also looking at genetic profiles and differences. So if we look at effects of sleep deprivation, and I put this up here because this is going to get tied into delirium, but sleep deprivation, you can see I've highlighted in the red, irritability, cognitive impairment, memory problems, hallucinations, which are all important for delirium, but also important for critical illness. You can see sleep deprivation leads to impaired immune system function, changes in heart rate variability, heart disease, and long-term, not so much in our ICU patients, but lots of literature about effects of sleep deprivation and diabetes and obesity. So if we look at the intensive care unit, there are multiple factors that interact to cause circadian disruption in the ICU. So obviously people are critically ill. The impact of their critical illness and treatment with release of cytokines and other organ dysfunction. There's lack of sleep opportunity, so people are going in, they're waking patients up, they're not given the opportunity to sleep. And then poor circadian cues. Again, the circadian cues being light, activity, being upright, feeding, social interactions. You've heard a little bit, well, you've actually heard a lot about this in the prior talk about environmental causes of disruption. But things that are important, again, are just light patterns, the noise, room temperature. Again, core body temperature is important for maintaining circadian rhythm. Patient activity, the fact that we can give patients continuous tube feeding, and obviously patient care interruptions. So just to switch and talk briefly for the next few slides about delirium and then tie the two together. So everyone knows that delirium is an acute confusional state, and it has key components. So you have disturbance of consciousness. By definition, delirium is an acute problem, so people don't have delirium for years. So it's acute onset, and it fluctuates over the course of the day. And remember, some of those fluctuations may be part of the tie to circadian rhythm. Patients with delirium have a change in cognition, and they often develop a perceptual disturbance. So they have inattention, they have disorganized thinking. And by definition, delirium is caused by physiological consequences of a general medical condition or their critical illness. As you heard as well in the prior talk, prevalence rates of delirium differ depending on severity of illness, in studies depending on the population screened, so surgical, post-op versus medical intensive care units, also depending on the instrument used and how frequently people are screened. So remember, delirium fluctuates. If you're screening once a day, you may be missing delirium. So lots of risk factors for delirium have been identified in the literature. There's predisposing and precipitating ones. As you can see here, the ones that are highlighted in blue are ones that are probably also related to circadian dysfunction, so age, severity of illness, limitation of patient activity by use of restraints or catheters. Medications can impact delirium, sleep, as well as circadian rhythm, pain, sleep deprivation, and again, immobilization. When we think about this in our patients and trying to risk stratify and work towards improving outcomes for them, we have to remember that many of our patients have many of these risk factors. So what are the possible interrelationships between circadian disruption and delirium? Well, there's a bunch of hypotheses proposed. And so one of them is circadian disruption a problem that then leads to delirium? So you get circadian disruption, it's your primary issue. The circadian disruption causes sleep-wake cycle disturbances, also contributes to the activity changes we see in delirium, so hypo and hyperactivity, impaired cognition, and fluctuation of symptoms. So really, is delirium a general disturbance of neural function due to circadian disruption? And again, our next speaker will talk about melatonin, so I won't talk a lot in detail about melatonin, but is melatonin a possible explanation for this, and is this the common mediator? The other flip side of that is, does delirium cause circadian dysregulation? So do you start out with delirium, and because you're delirious, you're not ambulating, you're not taking in food at normal times, you have impaired social cues because you're delirious. And because you're delirious, you're not really interacting with your environment. And then does that, in turn, lead to the circadian disruption? And again, so is delirium then cause an uncouplement of circadian entrainment? So you're delirious, you've lost your ability to have access to the cues that maintain circadian entrainment or rhythm. Another possibility is delirium a primary circadian rhythm disorder? So is delirium the circadian rhythm disorder that leads to the disturbance of the circadian rhythm system that then gives you your delirium symptoms? So now you have your inattention, your irritability, your perceptual disturbances, and your cognitive dysfunction. The other possibility is, are these just two totally discrete syndromes? So you have circadian disruption here, delirium here. They're separate, but they have shared symptoms, pathophysiology potentially. So you get sleep disturbance with both. You know, they're mediated by inflammation, ischemia, organ dysfunction. And then do they in turn feed off of each other? And so they perpetuate each other, they mutually aggravate each other. Another possibility, they're separate syndromes, but do they have shared risk factors? So with increasing age, we know that patients are more likely to get delirium. It's a major risk factor. But also with age, patients tend to have more circadian rhythm disruption. They have with age as well, they have changes in melatonin secretion. Dementia, again, risk factor for delirium, and we know that patients with dementia have circadian rhythm disruption. Many medications that are risk factors for delirium also impact circadian rhythm. So is it possible that the mechanism that links them is these shared risk factors? And then the last possibility, I suppose, is chance. So they just occur together by chance and are reflective of decreased physiologic reserve. So again, advancing age, dementia. I think, this is my opinion, that this is probably the least likely explanation, but the research is at a point where we don't have a good way to connect them in a total specified pathway that we can follow. So if we look at a little bit more detail, cognitive disturbances in sleep and delirium. So you can see here, they have, again, the same symptoms. With disrupted sleep, there's lots of studies in healthy patients, in trainees, that show that disrupted sleep causes memory loss, inattention, decreased reaction time, irritability, delusions, slurred speech, incoordination, which obviously are a lot of the things we see with delirium. You know, the definition for delirium includes fluctuating mental status, inattention, disorganized thinking. So sleep is severely impaired in the ICU, and you've seen some of this data already, but total sleep time is shortened, so patients sleep less. Their sleep quality is degraded, so they don't get the restorative stages of sleep. Most of their sleep is in the very light stages. They have much less REM or slow wave sleep. It's frequently interrupted, and it occurs at the wrong time. So studies have looked at this and have shown that 50% of total sleep time occurs during the daytime in intensive care unit patients. And again, that sleep at the wrong time is a marker of circadian disruption. And remember now that delirium is prevalent in the ICU, so these are tied together. When we look at the link between sleep deprivation and delirium, it's really not well established. There's probably imbalances in neurotransmitters and alteration in melatonin that contribute to both. If you look at the hypotheses related to pathogenesis of delirium, they include alterations related to tryptophan, which tryptophan is a precursor to serotonin, which is a precursor to melatonin. There's also hypotheses related to cholinergic systems, and all of those as well impact circadian rhythm and sleep. But when we look at the studies, the literature still is conflicting. Studies have shown that poor sleep increases your risk of delirium. Again, associations with delirium and decreased REM sleep. But there are also studies that show that converse, that sleep deprivation was the result of delirium, and some that have been unable to show a relationship between the two. And lots of these studies are small studies. Many of them don't have polysomnography as their standard for measuring sleep, or they didn't use validated delirium measures. So I think this is still a question out there, and more research is needed. Critical illness itself has both physiologic and care-related links to circadian disruption. So again, if you think about it, you're critically ill, you have multi-organ failure, including brain failure, causing sleep and circadian disruption. pain, anxiety, sadness have been tied to circadian disruption, as well as mechanical ventilation, and some studies that have looked at differing mechanical ventilation modes and the interaction between sleep and circadian rhythms. The need for sedation and restraints is a care-related link, right? If your patients are sedated or restrained, you have impacts on circadian rhythm. And then all the things we do to patients, diagnostic testing, monitoring procedures. And so, as I said, many of these physiologic perturbations are associated with the perturbations associated with critical illness have circadian components to them. So if, again, just to remind you, if you look, light is our strongest Zeitgeber, impacts the master clock, which causes circadian entrainment, which impacts our sleep-wake timing. But the circadian entrainment is also important to organ function, which obviously in critical illness is important. You want an intact immune system or a functioning immune system. The impact of circadian dysrhythm on lung function and weaning is interesting but hasn't really been well studied. And then obviously for delirium, the impact on the central nervous system. So there are many studies, or not many, but several studies out there now that have started to look at circadian rhythm in ICU patients. Severity of illness is a predictor of circadian displacement. One study looked at core body temperature in a small number of patients and demonstrated shifted circadian rhythms. Those patients were patients who were fever-free, not on antibiotics, and showed either an advance or a delay of circadian rhythm. And several studies now have come out looking at melatonin secretion and shown it to be impaired in ICU patients. And I'll give you a few slides of details. So this is a study Brian Galeback did looking at urinary 6-sulfatoxymelatonin excretion in 16 ICU patients. And you can see there's a delay in the onset of melatonin release in these patients. So these patients are shifted. This is another study that looked at not only urinary melatonin levels, but light levels in patients with severe sepsis. This was a small number, an N of 7. But again, you can see here that there is not a standard pattern for melatonin, and light levels appear to dip in the evening, which is good, but they are actually still fairly low in the morning times, which is when you'd want bright light for circadian entrainment. This is a study that came out in Chest in 2015 that looked at urinary melatonin patients in normal and delirious patients, and you can see that the delirious patients are the ones in the triangles and with the solid line, and the normal patients or non-delirious patients are the circles with the dashed line. And you could see that the patients that had delirium had abolished urinary melatonin, rhythmicity. This is some data from one of my colleagues at Yale, where she looked at actigraphy in patients in our intensive care unit. They were older patients, the mean age was 63, and they were actually more in the recovery phase of their critical illness, as you can see by their Apache 2 score. So they had been in the ICU for a while. 36% of them had delirium, and just if you look at the patterns, we saw multiple patterns. So there were some people who had normal circadian rhythms, where you could see the pattern on the very top panel, and then patients with advanced phase shifts of their circadian rhythms, which is the middle panel. And then if you look at the very bottom, there's an absent circadian pattern. So there's no pattern to their activity to suggest that there's a circadian rhythm present. This is also data from our ICU, and as you can see here, our ICU, if you look at the time, it's fairly bright still overnight. And as you can see, though, as time goes on overnight, our average light lux levels go down. But the interesting thing for us was that, again, the mean lux is still high over the 24-hour period, so higher than you'd want it at night to sleep. But if you look at, again, times where you should be having bright light to entrain your circadian rhythm, our light levels are still fairly low, and they don't get to be brighter till later in the day. And again, even if you look at our highest lux levels during the day, they're probably not high enough really for good circadian entrainment. This was a study that a med student did with us, where he went around and did point prevalence at the ICU at different times, so at 8 a.m., at noon, and at midnight. And you could see here, there's not much difference when comparing when there were bright lights on from morning versus night. So you were as equally likely to have bright lights on in the morning versus at night, television on all times of the day, and then window shades closed. Again, you were equally likely to have your window shades, or more likely to have your window shades closed during the day than in the evening. I'm not sure why that is, unless our nursing staff thinks that looking out at beautiful New Haven at nighttime is a good thing. But so this was kind of interesting for us to see what was happening in our ICU. This is the same study you saw in the previous talk. It's out of the Netherlands, where they looked at dynamic light application. And so you could see, yes, light levels were increased, and they didn't, but there was no impact on delirium rates in this study. And some of the thoughts I had, and what the authors had, is is the bright light bright enough? Is it at the right time? And again, as was mentioned previously, where a number of these patients were sedated, so were their eyes closed and they actually didn't get exposure to the light. I want to put a plug in for early mobilization in the ICU. It's feasible in patients with respiratory failure, obviously also with ECMO. You saw pictures in the last slide. It reduces hospital length of stay, but importantly, reduces delirium incidence. So, being upright, again, is a cue for your circadian rhythm. So is, early mobilization helping us maintain a normal circadian rhythm. If we want to think about intervenable things, we can talk about the environment. Our last talk did a great job of talking about the environment. I am so jealous now of that ICU and their lights and their setup, but environment is one place where we can intervene. And so what can we do for patients to try to help improve their sleep and their circadian disruption? Well, circadian signals, so again, light, feeding. We're moving away now from continuous tube feeding and trying to do bolus feeding that simulates a more circadian pattern. Again, getting patients up, mobilizing them, reducing sedation, having patients have social cues and interaction, and then providing sleep opportunities. So we've embarked on a whole, what we call nocturnal nap time, which is really a hands-off period at night to allow patients to have uninterrupted blocks of time to sleep, to get them through at least 2 sleep cycles overnight. So this is from Fitzgerald's paper, their paper that talks about delirium and circadian rhythm. And again, just to review, you have your circadian timing system, which you have entrainment of Zeitgebers. There's the suprachiasmatic nucleus pacemaker, and then the effector system that goes to the other peripheral organs. In the middle there, you have cognitive impairment, aging, and neurochemical factors. All of the hashed lines are potential pathways. The solid lines are known pathways. So you have your Zeitgebers, which are, again, as I mentioned, light, feeding, social cues, exercise. And then down here is delirium. So delirium, symptoms of delirium, altered motor activity, so hypoactivity, cognitive impairment, sleep disturbances, potentially related to melatonin mechanisms, And so there's a whole potential pathway for interaction here between circadian rhythm and delirium, which I think has potential opportunities for lots of research. This is our schematic from Yale about all the things that we think of that we need to impact on. So when you're trying to think of ways to improve outcomes in the intensive care unit, again, as was mentioned previously, thinking about noise, thinking about light, things we can do related to the critical illness itself, how we provide bedside care, and then also providing appropriate circadian cues. So Flannery recently had a review article that talks about research framework and things that we need to do to try to move the field forward. So really demonstrating the link between sleep interventions and improved sleep and outcome. And then in doing these studies, thinking about, there's lots of confounders when we're studying things in the ICU. So doing these studies in a setting where all the rest of the care is guideline recommended and standardized to reduce the potentials for bias. So, you know, where you're using daily awakening, standard sedation protocols, standard treatments or plans for delirium. So really you're studying the impact of one intervention. Delirium in these studies needs to be assessed with validated screening tools, really thinking about minimizing selection bias when you're choosing patients. And then, you know, many of the studies that are out there are very narrow and very specific patients, small numbers. So trying to use study populations that are generalizable to a larger majority of ICU patients. And so when looking at these studies, can the patients in these studies, are they applicable to the patients you're caring for? These are my own potential thoughts about future research directions. I think there's a lot of work to be done about pathogenesis of delirium. Is it the same in all settings or not? So animal models, human studies using objective measures for delirium. And I think later today you'll hear about EEG in delirium. More biological studies of circadian disruption. As I said, I'm not a circadian biologist, but I'm very fascinated by the impact circadian rhythm plays in many things: cancer treatment, timing of giving of medications, the impact of lots of the medications we use, anesthetics, for those of you who are anesthesiologists, on circadian rhythm. Medication treatment studies, so I think we need more and larger studies of melatonin or Ramelteon, and then all of this needs to be done in an interdisciplinary or multidisciplinary approach. So I'll stop there and say thank you. If any of you ever have the good fortune to be in the States and near New Haven, we welcome visitors. This is our medical school.
Yeah, thank you very much for this interesting overview and for your statement, your last statement, that we need really the chronobiology. Chronomedicine and chronobiology is so important, but it's no part of the study for students, it's no part in practice, in our treatment practice. It's unbelievable. Yeah, please, time for 1-2 questions. Yes, please.
Thanks so much for a fascinating overview. You've really nicely highlighted the ways in which the ICU is particularly detrimental in terms of some of the circadian rhythm issues. But we all know that sort of even in our own beds with a mild flu, circadian rhythm tends to go out the door. Are there any thoughts on why kind of humans have developed this response and possibility that aspects of it could be in some way protective when ill? Or is it just seen as a completely negative thing to have that disruption?
That's a good question. I'm not sure I know the answer to it. The circadian, the rhythmicity itself developed, I think, initially related to predator-prey, when is the best time, you know, to feed and for survival mechanisms. As far as disruption goes, could there be a potential benefit? That's a really good question. I don't
just sort of wonder, like fever, right? We know we
right,
have theories
exactly.
about why we
develop
a fever response, and just wondered whether there was any thoughts on that with related to this response in the body.
You know, I don't know. I don't know if anyone else who's more of a circadian biologist may know the answer.
Yeah, for myself, there's a question, what is really the problem? It's just a circadian entrainment, or it's a really circadian disruption? And therefore we need, Dr. Lutz mentioned it, we need the clock gene studies. Maybe the clock gene studies give us an answer in this topic issue. Yes, please, last question.
Thank you very much for this very. I remember one slide where you showed the course of light intensity on your wards, on the ICU wards, and you stated that especially early in the morning, there's not enough light. I wonder whether all these studies take into account that there are seasonal changes and that sunrise may differ up to 2 hours or more, depending on whether it's summer or winter. And another question would be, are there studies in the northern countries like North Europe with Finland, Norway, Oslo, in Oslo, for example, where it's more or less dark the whole winter season and it's more or less bright during summer? So are there any ideas from patients in these ICUs whether sunlight has effects on delirium depending on the season?
That's a great question. There's one small study that suggests that delirium may have a little bit of seasonality related to it, and so that may be light related. In our studies, we do take into account time of year and sunrise, but when I've looked at other studies as well, I always look to see where they're done, so which hemisphere they're done in, just to get a sense of, is some of the light stuff related to seasonality. There are studies, not necessarily in ICU, but outside ICU that do look at that, depending on where you are related to the equator. Thank you.
Yeah, thank you very much again.